All right. So Darla is our next speaker, Darla Spears. Darla is a board certified geriatric pharmacist. She received her bachelor's degree in pharmacy from the University of Oklahoma and earned a PharmD from the University of Colorado. She has experience as a vending pharmacist in long term care and an extensive background in clinical consulting and long term care. She has worked as a clinical science liaison in respiratory and cardiovascular specialty with a focus on quality measures and outcome improvement. She worked as a medical science liaison in oncology. Darla enjoys improving outcomes for elders and driving quality improvement in facilities. So without further ado, Darla, if you will share with us what you got to say today.
Well, thank you so much, Lisa, and thank you so much, everyone, for joining this webinar today. I want to take just a minute to thank people, particularly pharmacists, that have taught me so much about dementia care, but certainly and foremost, all the wonderful nurses who have shared and still continue to share great things about dementia care with me that they just don't teach you in pharmacy school. In fact, one of my first days in a nursing facility, as I sat at the desk, a director of nurses came by and leaned over, picked up a little cup and rattled it at me and said, "Here are some nickels." And she walked down the hall. Well, I was a little confused by this, but it wasn't very long before this fella showed up at the desk and said, "Ma'am, I need a nickel for the streetcar. I've got to get home. My wife's going to be really worried." Well, in all honesty, the word streetcar kind of threw me, but that little cartoon light bulb came on over my head and said, "Nickel." "Yes, sir. Here's a nickel." Well, I handed it to him and he seemed to go off happily down the hall. I saw this same scenario play out just over and over during the day with various staff members. So you may be thinking, this facility had wonderful non-drug interventions for their dementia patients. And yes, in fact, they did, but it gets a little better. That director of nurses shared with me, along with the pharmacist that I was with that day, that that gentleman had come in a few months before taking a big dose of Haldol for combative behaviors. But because of the extraordinary efforts of this director of nurses at finding his trigger, at really developing a great care plan, at educating his family, educating the staff, and then working with the pharmacist, they were able to taper that Haldol dose down, and he was living the existence, this peaceful existence in the nursing home that I saw as an example. So that to me was so impactful. But one of the last things this nurse shared with me was, "I want you to remember as a pharmacist that sometimes you don't need medicines. Sometimes you just need nickels." That impacted me pretty profoundly. And I know many of you who care for these patients have very similar success stories. So from that frame of mind that we always want to use non-drug interventions when possible, we're here today because we know that non-drug interventions don't always work, or as dementia is a progressive disease, they begin to not work anymore. When medications become necessary, how do we navigate CMS regulatory requirements? How do we align with quality measures while providing that very patient-centered care? Well, today, we'll recognize medications that are now considered to be psychotropic. We'll look at the CMS regulations surrounding the use of these meds and some monitoring. We'll discuss the FDA approval of an antipsychotic medication for the treatment of agitation associated with dementia due to Alzheimer's, and we'll describe some key elements of psychoactive stewardship. I wanted to give a little background because I know we have a lot of people who are new to long-term care. Psychotropic medications have been a focus for CMS for a very long time. In 2011, CMS noted that 24% of elderly nursing home residents were prescribed atypical antipsychotics, and further, less than 60% of care plans for these medications had any sort of family involvement. Also, only 3% showed that an interdisciplinary team had participated. So CMS recognized this as a huge problem. So they developed a strategic approach to driving change within long-term care. So a couple of things that they did were, first, they formed a partnership with caregivers and national organizations, and its mission was to enhance non-pharmacologic approaches and patient-centered care. They would measure the success by the percent change in long-stay residents who received these very dangerous medicines. They did, however, exclude patients with diagnosis of schizophrenia, Tourette's, and Huntington's. So there were what we'll call the CMS exclusionary diagnosis. Another driver of change was quality measures, particularly quality measures that impact the nursing home's 5-star rating. So as you can see, in 2015, a quality measure that looked at the percentage of residents who received antipsychotic medications, excluding those CMS diagnoses, would be tracked. So I want to take just a second and point out diagnosis. Diagnosis becomes very critical for a lot of reasons, patient care and regulatory. So one key take home for today is diagnosis. I would urge you, when any psychotropic medicine is prescribed, to be sure that that diagnosis is available, that it's accurate, and that it's appropriate. And you'll begin to see how very important that is as we move on. Now, one more driver, the survey process. During survey, over the next years, many facilities were cited for unnecessary medications, and quite a few paid some pretty hefty monetary penalties related to antipsychotic use. What happened in the big picture was, during that period of time, thanks to a lot of diligent efforts, we saw some pretty impressive numbers. In that 10-year period, there was a significant reduction in antipsychotic use as reported by CMS. But there are two things probably we need to look at. During that same time frame, CMS recognized in 2015 that it appeared that patients were being given schizophrenia diagnosis. There had been a 35% increase to help them better align with those those quality measures that might impact their 5-star rating. And also, the Office of Inspector General noted that during that same time frame, when our antipsychotic use was decreasing, there was a pretty significant increase in the use of anticonvulsants, which can also be very dangerous for elderly patients. CMS has responded strategically with an increased survey focus on the use of anticonvulsants in nursing centers. And as we move forward, in addition to the 4 classes of medications, which we've always considered to be psychotropic, any medication now that can affect brain activity, like antihistamines or anticholinergics and various other CNS drugs, when their use appears to be a substitution for another psychotropic medication, should be treated as though they are psychotropics. So now that we're all caught up and we understand that there's survey focus on diagnosis and there's survey focus on how we handle these medicines, let's check in. Ms. Abway has been admitted for skilled care. Her medications include Seroquel, 25 milligrams, and she's also taking daily doses of lisinopril, furosemide, potassium, iron, and pantoprazole. Very limited information came in on the hospital paperwork. Ms. Abway is a poor historian. What things are going to be very important about that Seroquel diagnosis? Do we have a response here? Let's see. Okay, peeps,
Yep, they're still coming in.
still coming in. Well, spoiler alert. Well, we're not getting a lot of responses really quickly. I should have given you more of a heads up, but I cannot emphasize how important getting those diagnoses are. Okay, are we ready to move on?
Absolutely.
Great. Okay. All of the above. So let's take a look at our psychoactive medicines, and we'll go through them pretty quickly by class. I've listed for your reference the first generation antipsychotics. You can see that their diagnosis align pretty quickly with those CMS exclusionary diagnoses. The most common meds we'll see as far as psychotropics go will be the second generation or atypical antipsychotics in long-term care. We know that these medications probably won't be diagnosed for one of those CMS exclusionary diagnoses. However, that does not mean that they are inappropriate. All it means is that we need to look a little further. For instance, the FDA has now granted approval as indications major depression for some of these medications, and also 8 of them now have FDA approved indications, which means they have been shown to be safe and effective for use in bipolar disorder. Additionally, one of our second generation medications is approved for use in Parkinson's psychosis, and now one of these medications is approved for the treatment of agitation associated with dementia due to Alzheimer's disease. Now, there's a lot of information on these slides. In the interest of time today, I'll just point out 4 things about brexpiprazole. I'd encourage you to look at the manufacturer's labeling, and I have referenced the clinical trial publication at the bottom. The most important things for today is when patients in the trial were up titrated to 2 milligrams of the brexpiprazole, they did show a statistically significant reduction in agitated behaviors. Brexpiprazole is not indicated as a PRN treatment. That's the second thing. Brexpiprazole still carries the black box warning, although its wording is a little bit different than the other atypical antipsychotics. And as far as adverse events go, patients who took that 2 milligram dose did have more urinary tract infections, and they did have a little more dizziness. So I think the take home today from antipsychotics as a class is just because they do not have one of those CMS exclusionary diagnoses, we should not necessarily view that as inappropriate. There are absolutely other FDA approved indications for these medicines, and taking them off these medicines could be quite detrimental. So let's move on to anti-anxiety agents. We're all familiar with these. I think you can see that the vast majority are benzodiazepines. We tend to steer clear of benzodiazepines because we know that they are associated with a lot of adverse effects in the elderly. If possible, your consultant pharmacist may be trying to help move those or change those to alternative medicines. We know that hydroxyzine does have a lot of anticholinergic side effects that would be associated with confusion. On a practical standpoint, from a consulting, I visit your facility, we know benzodiazepines have negative effects in the elderly, but as I watch things play out during the day at the nursing home, I'd also like to ask you, how much time does your staff spend eliciting prescriptions for these controlled substances and, making count sheets and counting these meds at shift change, particularly if they're in bottles? So, obviously, we always focus on great patient care, but for some practical reasons, we want to try to also switch away as well. Antidepressants are by far the most widely used psychoactive medicines in nursing facilities. There are a lot of reasons for that. elderly nursing home residents have depression for a variety of reasons. However, these medicines are also often prescribed for insomnia, or in the case of mirtazapine, maybe for appetite stimulation. I will point out that many of these meds, especially the SSRI class, has a few agents that are also approved for use in anxiety. So if we're looking for alternatives, one of the things you may see your consultant pharmacist do is try to shift some people with, those less favorable anti-anxiety meds over to an antidepressant that may have more favorable side effects and also actually treat anxiety quite well. If they happen to have both disease states, this might be a great opportunity to use just one drug in place of two, obviously reducing side effects and cost. Then we have our sedative hypnotics. I think that we can all agree that we use these medications in the lowest dose for the shortest duration. One of the things I'd like to point out is that one of that your consultant pharmacist may be doing within their review is looking at stimulant medications and, of course, eliminating or moving them earlier in the day. But I'd remind you to keep a focus on diuretics. Diuretics given too close to bedtime, or especially in a situation that their dosing could have been increased to twice daily recently. Perhaps that last dose is given too late in the day. We're having urge at night that's disturbing sleep. This sometimes I see in practice as I come in to look at charts in the facility. Sometimes I will see a hypnotic has been ordered shortly after that. So this is a great opportunity to eliminate that medicine and, of course, move that diuretic to earlier in the day. There is melatonin, and I didn't list it as a drug because it is considered to be a dietary supplement. This is also a great option for some residents. So now we come to this other class of medication. And if you're here with me in polling, or if you would be willing to answer a question in the chat, when we looked earlier at the slide that showed the reduction in antipsychotics that had coincided with the increase in anticonvulsants, how many of you had the thought that I had of pregabalin and gabapentin that are so frequently prescribed for neuropathic pain? Is anyone in the chat? So I think over the last 10 years, we've seen so much gabapentin prescribed for our diabetic patients that we can all agree that these are more frequently prescribed. And this can account for some of those increases. But as we look, in general, we see valproic acid is typically the agent that is added for these behavior type symptoms. I would just urge you to look at these medicines when we're evaluating why residents are receiving them, and if they are for an indication that is not one of their original FDA approved indications, that we're sure that we're aligning with federal regulations regarding their administration. So let's see here. All right. What are these federal regulations? I've listed for you the federal regulations which are most commonly associated with psychoactive medications. F757 is that F-tag that looks at unnecessary meds. So in short, it's that regulation that says a medication can be deemed unnecessary if we're giving too much, if we give it too long, if we don't monitor it, if it doesn't have an adequate indication, or if we have adverse consequences and we don't take action. F758 aligns more closely with our psychoactive medication, and it's the regulation that looks at how, when, how long we can use these medications. As we looked at before, for any medication and any psychotropic any psychotropic medication, having a diagnosis that is available and that is accurate and that is appropriate is crucial. But when it comes to antipsychotics, we do take a bit more care because they get a bit more scrutiny. I'd like to direct your attention to the indication of dementing illness that requires treatment with an antipsychotic medicine because this resident's behavioral symptoms endanger themselves or others and they don't respond to non-pharmacologic treatments, and you must have those specific behaviors documented. I see a lot in facilities and chart review that dementing illness without behaviors has been selected. And we never know if that's really just a clerical error, but that's definitely something we'd want to address. I will stress that diagnosis alone is not sufficient for administering medications. And then permission given by the resident or their family to administer a medication just doesn't serve as a sole justification for administering one of these medications. So let's take a minute to look at that schizophrenia diagnosis. Absolutely, residents of long-term care may have valid schizophrenia diagnosis. However, it would be very uncommon for schizophrenia to have been diagnosed in someone who's older than 40. CMS says that schizophrenia must have been diagnosed by a qualified practitioner using evidence-based criteria and professional standards. And be very aware that CMS does not take lightly giving patients who don't have schizophrenia a diagnosis of schizophrenia simply to better meet quality measures or improve 5-star quality ratings. In fact, the language that they're using indicates that, this may require a referral by the nursing staff or the survey team to state medical boards or boards of nursing. And that's pretty strong language. We really haven't seen that in any situation before. So I will say that anytime a patient has schizophrenia, you're entering that schizophrenia diagnosis, know that it will be checked. So having that good documentation in the chart, in the prescriber's progress notes is really important. And when I say checked, CMS does this with remote audits, and they do it as part of the survey process. Non-pharmacologic interventions. Well, we know that CMS's stated mission is to enhance non-pharmacologic approach to dementia care. So it's really important that we do have our interventions and that they are, as my wonderful nurse in the example that I gave you, use individualized non-drug interventions, that they be care planned, and that we're charting them, even though we may also be using medications. We chart them when behaviors occur, and we also need to chart the non-drug interventions that we attempt prior to giving a PRN psychoactive medication. Paramount, before any psychotropic medication is ordered, we do need that documentation that multiple attempts were made with non-drug interventions and that they were unsuccessful. Because, again, this is the goal of the partnership that CMS has to improve dementia care in nursing homes. Gradual dose reductions are required by CMS, and your consultant pharmacist is probably taking care of those, keeping you on track with these. Within that first calendar year, it is required that 2 reduction attempts be made in separate quarters, separated by a month. However, your consultant pharmacist may be looking at reductions as appropriate in times such as fall, if the resident has a change of condition, or readmissions and admissions. But there's a little more to GDRs that I want to focus on. When the pharmacist makes that recommendation, the clinician must respond to the recommendation. If reductions are attempted, that is evident on the chart. However, If the clinician or the interdisciplinary team has decided that reductions are inappropriate, we must have an appropriate response back on that letter. I've listed what CMS considers to be appropriate rationales for not reducing. Those basically focus on previous gradual dose reductions that have failed, symptoms have reemerged, or the clinician provides a reason that reducing would be harmful to the resident. Or in the case of schizophrenia, looking at destabilizing that underlying disease, because many times reductions in this population, it's just not possible. But I will remind you that that documentation needs to be readily available. I see a lot in survey that when all of these elements have been in place, but the surveyor isn't seeing those reductions and asks for documentation, if these records aren't readily available that we can share with survey, oftentimes these 3 citations above, almost the trifecta of deficiencies, you're cited for dose too high for too long, failure to reduce, and then failure to act on the pharmacist's recommendation. So as a matter of housekeeping, if you are using paper, you might want to even consider keeping paper copies of those reductions in a file in the nursing office, just in case. PRN psychotropic medications. I want to emphasize that hospice is not exempt from the stop date, from these 14-day stop dates. Antidepressants, anti-anxiety meds, sedative hypnotics, and now possibly even some of those other category meds, when they are ordered on a PRN basis, have to have an initial 14-day stop date. During that 14 days, the staff and caregivers have time to establish if non-drug interventions will adequately manage or if routine therapy is needed. However, if a clinician decides that continued PRN therapy is most appropriate, we have to have a rationale provided and a duration of therapy. If an antipsychotic is ordered PRN, which they rarely are now, but if this happens, this is a hard 14-day stop. If this is to be continued, the physician must come and do an in-person assessment of the patient and issue a completely new order. But here's where I see this crop up a little. I find that a lot of hospitals are using the old antipsychotics like prochlorperazine for nausea. So watch those orders when patients especially are coming in for skilled. If they have one of these orders in place, we'd like to get those changed if possible to something like our Zofran's. But if not, beware that this is a potential area for citation for your facility and we'll need that stopped within 14 days. All right, here's our last. When we have psychoactive medicines that are used for non-psych symptoms, like nausea, like insomnia or itching, all of these stipulations still apply. So, for instance, if we're using hydroxyzine hydrochloride, which we know is an antihistamine, if we're using Vistaril, hydroxyzine pamoate, if we are using it for itching, we still have to monitor it because its effects will be present regardless of use. And CMS does say without exception. All right, so is everybody ready for a couple of questions? Mr. Littlejohn. Mr. Littlejohn has a history of, just a second, let me get to my question. He has a, I apologize. Mr. Littlejohn has a history of hypertension, diabetes, and bipolar disorder. He's prescribed lisinopril, metformin, and cariprazine 1.5 milligrams daily, sertraline 100 milligrams daily, and difalproex 250 milligrams twice daily. Which of these medicines, based on what we've gone over today, are going to require non-drug interventions?
Darla, while they're answering, let me share with you a couple of questions that have come in, and that'll give them a minute to go ahead and get their answers in. Is that okay?
Absolutely.
All right, we've got one question that came in. I've been seeing more and more use of PRN gabapentin for BPSD and dementia, and also PRN boost bar for anxiety. In my experience, gabapentin takes a really long time for any effect, and boost bar requires routine dosing for any benefit to be noted. What has your experience been with this, and do you have any tips on changing prescriber habits?
Well, what I will say to that is absolutely, I agree with you 100%. I do not understand how gabapentin could be effective PRN. Buspirone also takes quite a while to have effects. So I think writing letters, I do send recommendations to physicians that state exactly what you stated. This is not likely to benefit, and trying to provide education if I can at QAPI meetings. That's a great time to really get in touch with physicians, and then also the floor nurses. Every once in a while, I find that a physician is merely reacting to what a nurse has asked for. So I try to, within in services, make clear what may provide benefit and what won't. But I completely agree with you.
Okay, and one more question that's come in. Does the 14 days stop regulation apply to hospice patients?
It absolutely does. If you'd like to reach out to me afterward, CMS, when they initially rolled this out, did a question and answer session with surveyors during survey training. And one of the surveyors actually asked, we see these meds in our hospice patients. They are very necessary. Why are they not excluded? And the response almost seemed a bit terse, but it went something like, we are aware that hospice clinicians may review their patients every 14 days, and they are welcome to do so or more frequently if necessary. Absolutely, CMS requires this to apply to hospice.
Okay, it looks like the answers have slowed down on the poll, so we'll go ahead and review those.
All right. Well, absolutely. All of the above. All right. Thank you so much for participating. All right. Next question. Antipsychotic medications have varied FDA indications. My patient is taking prochlorperazine PRN for nausea related to chemotherapy. No AIMS monitoring. No 14-day stop date is required. And is this true or false? All right. Absolutely. Absolutely. You're all A+ participants today. All right. Our next question. Ms. Rodriguez is prescribed lorazepam 0.5 milligrams every 6 hours as needed for anxiety associated with the end of life. Lorazepam is an anti-anxiety medication that requires 14-day stop dates if used PRN per F750A. This does not apply to this order because Ms. Rodriguez receives hospice services. True or false? All right. That is correct. That is absolutely false. And we did just talk about that. So let's look at some monitoring parameters that will keep us aligned with regulation. Here's some general things we'll cover. behaviors, efficacy, of course, adverse consequences, non-drug interventions, and then things like labs, falls, weight loss. So when it comes to behaviors, I've listed a few behaviors that typically would look at what we're monitoring and what we're charting. I think what's very important is that behaviors are mandatory. Behavior monitoring is mandatory for antipsychotics, anxiolytics, and now any other medication that's used for a behavior. And I'll also throw in, now that so many of our SSRIs and I believe 2 of the SNRIs are indicated for anxiety, if we're using them as anxiolytics, we need to be sure that that behavior monitoring component is in place. I get a lot of questions about, well, what does good look like? I'll ask you some questions back to that. Does your behavior charting give sufficient information that your interdisciplinary teams can determine if the therapy is working? Is it meeting the goals in the care plan? And of course, do they show harm to self or others? Does your documentation demonstrate frequency and severity? If Miss Smith hit someone, once 3 months ago, does that really give us a sufficient behavior type status that we wouldn't attempt a reduction? And then here's where I see a lot of people get into trouble in the survey realm. Are we continuing to chart behaviors, even if this behavior is something that's really common to the resident? If you're not doing that, it is very important that you start. Monitoring of antipsychotics is a little bit more complex than other medications because they do have such potential for such profound and sometimes irreversible side effects. One thing I'll point out that metabolic side effects are very common, particularly with the atypical agents. Watching for weight gain and then getting those periodic A1Cs and lipid panels is really important. And of course, we're all aware of the neurologic effects. We need aims at baseline, and then we need to continue monitoring those quarterly so we can assess for emergence of those symptoms. When it comes to monitoring for adverse consequences, a lot of things may happen more subtly than simply monitoring adverse effects. For instance, hypersensitivities, these idiosyncratic responses, and then potentially adverse medication interactions. So we'll look at all of our medicines for these types of consequences, and I have added for you some of the most common adverse effects that we see for the various classes. One thing that I find a lot, and I see come back maybe as a problem on survey, is sometimes we tend to have more vague charting of some of these more common adverse effects. So what I'd like to prepare you for is during the survey process, it might not be uncommon for a surveyor to approach a staff member, such as a nurse, and ask, do you monitor for adverse effects of your, let's say, anti-anxiety medications? And of course, their answer is going to be yes. Their next question may be, okay, tell me 5 side effects. We need to be sure that this information is readily available because we can all get that deer in a headlight moment, but we need to be sure that our staff really understands what they're monitoring and understands how and where they can find it. This is always listed in the care plan, whether you keep lists, but it's really important that staff is actually looking for these things. When it comes to antidepressants, I'm trying to find a good place to talk about this, so I just thought I'd toss this in now. We use antidepressants widely. It is very common for SSRIs and SNRIs to have some reduced sodium levels, so it's very important that we at least be getting the BMPs or the chemates occasionally. And then when it comes to monitoring parameters for these non-traditional meds like the anticonvulsants, I think it's really important to stop and say, I know we're probably not using them at quite the doses we would use if they were being used for seizure disorders. However, that's not always the case. It's still important to get periodic serum levels for these medications. We need to be looking at renal function, in some cases hepatic functions, and CBCs. Valproate can have some hepatic effects. Lacosamide is very sensitive to renal function. In our elderly patients, levels tend to run higher. And then, of course, it shouldn't be used in patients who have severe hepatic impairment. And remember that lamotrigine and carbamazepine still have a lot of blood dyscrasia. So you want to watch those CBCs. So, okay, here we are back at questions. And I know I also multitask during continuing education sometimes. So I'll give you a minute to get the screens open and wiggle the mouse. Okay, Mr. Green is 56 years of age. He's prescribed bupropion XL 300 daily, aripiprazole 4 milligrams daily for major depressive disorder, recurrent. His weight is stable. His AIM score is 0. He's also prescribed trazodone at bedtime for insomnia. Which of the following are true? We are going to want to do periodic assessments of A1C and lipid panels. Are those appropriate? Okay, B, aripiprazole is an antipsychotic. He has no diagnosis of schizophrenia. The physician should be contacted to discontinue aripiprazole therapy, as this will impact quality measures for antipsychotics. During the first year of therapy, gradual dose reduction attempts should occur unless clinically contraindicated in 2 separate quarters, separated by at least 1 month, or none of the above. And let's see what you think about that. Ah, okay. So absolutely, we need lipid panels and A1Cs. Aripiprazole is an antipsychotic, and yes, it's going to impact your quality measures. I don't know that will impact 5-star ratings because there's a little more to it, but it will count. And it will count in your, I shouldn't say that it will impact your quality measure because there is some variance, but it does count into that percentage, is what is more correct to say. However, these medications are FDA approved. This one is FDA approved for the treatment of major depression. He is on another antidepressant. It is being used adjunctively. We can always double check that. But in this case, having it discontinued might send him into a bout of major depression. So probably we wouldn't do that. We know that standard C answer is correct because CMS mandates that type of reduction. And then, well, none of the above. Well, message me. We'll talk about that. Okay. Okay, so let's move on. So as we've talked about throughout this presentation, we know that our goals as caregivers are, stabilize our patients, improve their quality of life, improve that functional capacity. We want to do that while minimizing negative outcomes, especially when medications are used. We do need to achieve regulatory compliance, and we do need to align with 5-star quality ratings. That said, what can we do better, and how can we work better to achieve those goals? Well, there's a lot of talk about taking some of the great lessons we've learned from antimicrobial or antibiotic stewardship and applying them in psychotropic management. Now, the regulations, CMS regulations, inherently have some stewardship measures built in. I think very competent and very driven providers already are practicing stewardship, but what might we do better? Well, let's dive in. Having that commitment from leadership, especially including psychotropic stewardship activities and job descriptions, helping make sure that when you have ancillaries or when you have consults, particularly, your psych consults, are we making clear that we need all of our paperwork back? We need those progress notes. We need to see why these therapies are in place. We need leadership to communicate expectation, as in, if recommendations aren't coming back in a timely manner, is management stepping in to either help our medical director follow up or help these providers understand how important that is? If hospice is continuing to issue orders and not giving us stop dates, is our administration willing to help us work with hospice to understand how important that is? And then, of course, reward improvement. We all like to be rewarded for the hard work that we do. Medical directors can establish a lot of standards that can be very helpful in managing psychotropics. I'd love to hear, if you're in the chat, some of the things that you may be doing that align with your antimicrobial stewardship type activities. We know that medical directors can establish that orders for medicines won't be given unless an appropriate diagnosis accompanies. I'll ask you, do you tolerate Z-Pak orders for cough? Most medical directors now do not. Do we tolerate orders for Seroquel that are given for insomnia? These are ways that your medical director can establish standards that will help us in our overall processes. And of course, directors of nurses are just amazing in the influence that they have on how nursing assesses behaviors, how they follow up on behaviors, how they try non-drug interventions, and how they approach clinicians when they are seeking out a medication for behavior management. And then, of course, your consultant pharmacist is always looking at policies, procedures, and regulatory adherence. Your consultant pharmacist will also be a great source of drug expertise. As we talked about earlier, they may be helping you use one drug in place of two, or what I see a lot in assisted living particularly is patients may have what I call a cocktail of medications. Maybe 1, 2, or even 3 very low dose antipsychotic medicines. One of the things that we can do is help prescribers understand that, of course, this is very costly, but sometimes optimizing one dose might eliminate the need for other drugs. And then taking action. I love to do just this portion of this in-service with nursing over Lunch and Learn to get their feedback. I have one facility that did implement something that has been really impactful. In addition to their standard protocol for how a clinician would be contacted if a patient's behaviors were not responding to their non-drug interventions and these behaviors were escalating, would to ensure that any gradual dose reduction that had been attempted in the last 3 months is part of that conversation. This has really helped us. Of course, your pharmacist is probably going to come in and try to take care of that after the fact, but getting that conversation started that a reduction was attempted at this time, these behaviors are reemerging, often deflects that urge to say, add some Depakote or add some Seroquel. This has been really impactful. So reporting. As we look at our antimicrobial stewardship and we track, I'll just ask the question to my nurses on the call. If we're thinking in terms of antimicrobial stewardship, what do you do if you're seeing a lot of urinary tract infections on one hall and the cultures are coming back for E. coli? In the chat, what do you do? Well, what I see happening is nurses stop immediately and educate their staffs on pericare, because that may be the issue with these UTIs. Well, what do we do if we see that one hall is getting a lot of new orders for hypnotics or an anxiety medicines? Are we stopping and re-educating staff members on their approaches and the appropriate use of non-drug interventions? Tracking reporting can really impact how many residents end up taking medications for behaviors. And then education. Within the realm of education, there are so many great ways that we can take steps to educate all of our providers. If we have new clinicians coming into long-term care, we can make sure that they understand our regulations that surround the use of psychotropics. We can take steps to make sure that hospice understands that, yes, we do need those 14-day stop dates. And while we absolutely value hospice's great service, we're not asking them to change the way they operate. We need the documentation. Are we taking steps to educate the family members? Do family members understand the purpose of dose reductions? And do they have realistic expectations for the use of pharmacotherapy? So I think as we look at so many of these components, I would love to get feedback from you on different things that you're implementing that may resemble things that we're already doing with antimicrobial stewardship to improve our outcomes with psychotropic stewardship. Whoops, pardon me, wrong direction. Let's take a question. Which of the following are true for psychotropic stewardship initiatives? They are required by federal regulation. Facility leadership is critical for success. And the consultant pharmacist may provide valuable drug expertise. Okay. Are we having any response? Let's
We
see.
are. They're coming in. They're still coming in. So we'll give them just another couple of seconds.
All right. Absolutely. I love this. Well, so I'm going to say formal psychotropic stewardship programs are not actually required by CMS, but facility leadership and consultant pharmacist, pardon me, but facility leadership is critical and consultant pharmacists may provide valuable drug expertise. So I agree with you in the overarching theme of, yes, we have to provide stewardship at some level. But when it comes to requirements from CMS, formal programs aren't actually required right now. All right. Let's move on to our very last question. Anne is an 87-year-old resident who, whoops. Okay. Anne is an 87-year-old resident who resides in memory care. She has a diagnosis of Alzheimer's and has occasionally requested PRN acetaminophen for her knee pain, but due to the progression of her dementia, she's less verbal now. A new order for valproate ER at noon for sundowning behaviors was issued yesterday. Charting has shown an increase in pacing and grabbing of medication staff, but it's noted both morning and evening. There's been no pain assessment or PRN doses of acetaminophen charting. What actions are appropriate? Do we request a valproic acid level? Do we educate staff members on reporting of symptoms of pain to nursing for assessment? Do we request a drug regimen review from the consultant pharmacist? And do we assess Anne for symptoms of pain? Consider a short-term order for routine acetaminophen and contact the prescriber for reassessment of need for the valproate 250. Mhm. Whoops. Okay, absolutely. The reason I didn't request a valproic acid level because this was really a very recently ordered therapy, so probably blood levels won't tell us much. But yes, absolutely educate the staff. Absolutely request that drug regimen review, and then also make sure pain isn't driving Anne's behaviors. Okay, well, you have been wonderful participants today. In summary, we've covered that diagnosis is crucial. It needs to be available, accurate, and appropriate for many reasons for our psychotropic medications. We know that CMS regulations that are normally associated with those, traditional 4 classes of psychotropics now need to be applied to other medicines when used in place of a psychoactive medication or the appearance of use. Regulatory compliance regarding psychoactive meds provides a framework for best practice of these medications. And psychotropic medication, one, is now approved by the FDA for agitation associated with dementia due to Alzheimer's. Last, psychoactive stewardship initiatives may increase judicious use of psychoactive meds and facilitate increased regulatory compliance. So I want to thank you for participation. Are there any further questions?
Thank you, Darla. As of right now, I don't see any that have come in, but anyone who's got any questions, feel free to put them in the chat or the Q&A, and we can certainly have a minute or two to address those.